part of their trauma. See that orange chair? Was that there when you were being traumatized? Well, no, we didn't have orange furniture. Good. Look up at that interesting chandelier. Was that there when you were being traumatized? No. But real clear sensory discrimination to help a person kind of get some observing distance from a flashback. Really helpful. Another thing we do is using the person's kind of dissociative or auto-hypnotic capacity to manage their own symptoms. Quick example, somebody's in flashback yelling and screaming in your office. We'll say, "You're willing to try something?" I say, "Yeah. I'd like you to take the flashback that you're seeing and see it over on that wall, please, on the count of 3. 1, 2, 3. Do you see it over on that wall?" "Yes." "Okay. Do you see it over on that wall?" "No." "Can you make it go from that wall to that wall?" What have you just done? For those of you who are trained in hypnosis, you know what this is, but what have you just done when you've asked a person to do that? Suggestion. You've demonstrated to them that the symptom is not overtaking them. They're actually able to control the symptom even though it's an awful experience. Once you do that, it is so much easier to learn to manage flashbacks once you've demonstrated to somebody, boy, they already can, by using that auto-hypnotic capacity. Then we'll say, "Can you imagine that flashback on the wall? I'd like you to imagine," you know how you turn off the old style TVs and the picture would fade out? "I'd like you to do that right now on the count of 3, please. 1, 2, 3. Okay, what just happened? Nothing, he's still there. Okay, let's try it again. You might have to, it doesn't happen the first time. But when it clicks and the person says, "You know what, I don't see it anymore," you've made a major step forward in helping that person regain a sense of self-efficacy. Now the problem is 5 minutes later they'll be in flashback again. That's okay. Because what you want them to do is develop and practice these skills over time like you would any relaxation or imagery technique. Regular practice over time. But we use hypnotic techniques to help control and manage the symptoms. It doesn't take them away, but you give them tools. And that's a big part of that first phase. I'm not going to go through all this just because I know we're going to go over a little bit, but creating an internal safe place, common image technique, imagery technique where you go to the beach or whatever your safe place is, can be really helpful for people with DID who experience themselves as divided. So you have someone in front of you who's in distress and you'll say, "Can you go to your safe place and allow some other part of your mind to come forward who is not in so much pain?" And then you can do if you're trained in hypnosis, you can really enhance this by using kind of complicated suggestions. But basically the idea is the person who's in flashback is also in an auto-hypnotic state. You can manipulate that, or they can manipulate it, you can, to their advantage. And that's what you're trying to do with all these techniques. You talked about sort of the middle stage with DID. One other issue we should talk about is the idea of termination. When you've done therapy like this, it can be a little daunting for the client to then kind of go from doing this kind of intense work to termination. So these tend to be longer therapies. A lot of people have taken the approach that they do indefinite follow-up because some of the attachment issues are so strong that to completely terminate, some people will not get better because that's the threat. So I have had clients where they come back once a year for 30 minutes. And that was enough. For whatever reason, that was enough for them to terminate therapy. They didn't terminate, right? We did indefinite follow-up. But literally once a year for 30 minutes. So you just have to gauge, is your client has their attachment systems been so damaged by the trauma that they're not going to be able to tolerate losing you? Old school was, no, we have a definite termination. It's abrupt. We might tail it down a little bit, but you got to stop. And you can make that case too. But a lot of people who do this kind of longer term work, especially if you get into the phase where you're doing trauma work, you have to gauge the risks and benefits of doing anything, including an abrupt termination. So almost always we phase out slowly, and for some people they just can't. I usually have kind of an open door policy that as long as I'm practicing, if you want to come back 5 years from now and check in, just give me a call. I don't usually schedule something a year out. I've never done that, actually. I had one client where she needed to know she could come back. And after a couple of years, she stopped doing it. But for about 2 years, then I just moved my office. Completely flipped her out. She was back in intensive therapy for another year. Anyway, speaking of termination, I ran over. I apologize. I'm going to stop now. Why don't you talk a little? Questions, comments, reactions, clinical vignettes, anything else?
I'm just wondering whether, I mean, assuming you get consent from the patient, have you ever like used a video, what he's doing now, video the patient on his altered states to show him? Does that help, or was it?
No. Well, we've used videotape for a number of reasons. I don't do it anymore. This was in the good old days. The good old days meaning we were doing sodium amytal interviews. Maybe a psychiatrist trying to get at memory by using amytal. We don't do that anymore. But the idea of videotaping, there was a school of thought, exactly what you said, of let's videotape, show the client so that they have some confirmation. But guess what they do with it? They dissociate that. They dissociate that they watch the tape. If it's too intolerable to bear, it's too intolerable to bear. So often forcing it won't get you there.
So they cannot recollect and watch the tape.
They'll either watch it and not recollect, or they'll watch it. Do you know what a negative hallucination is? In hypnosis, where you don't see something that's there, they'll literally watch it and not see it. It's a subjective report. They'll watch it, but they'll be looking at a blank screen in their perception. So in other words, they will not relinquish the defense enough to take
so you
in.
can't use it to help them to confront.
Yeah, not usually. When they're ready, see that's the catch-22. When they're ready, it would work. But by the time they're ready, you don't need it. It's going to happen. It's going to happen naturally.
I'm just wondering about EMDR and all this. It wasn't mentioned in this discussion, but is there a role to integrate and all this stuff?
A lot of people believe that there is. And I'm more comfortable with EMDR for more kind of acute trauma. But I know people who, I know very respected colleagues who use EMDR with complex PTSD and dissociative disorders and do real well with it. I just think you really, if I were going to do that, I would get a lot more training and a lot of supervision around it, because I don't use it every day.
Okay.
If you do, I know people who it's really been helpful in particularly that first stage goal of affect modulation and processing of trauma, being able to modulate it. EMDR works well for that for some people.
Okay.
So, but I've never used it outside of acute trauma. So, and I see a lot of folks with this stuff. I just don't do it. That's my own discomfort, more so than the therapy that doesn't work. I know a lot of people who love it. So,
Thank you.
my pleasure.
Well, I think